Hi, welcome back to the channel. Today I'm talking about melasma, so I thought I'd give you an update on what I'm doing with my melasma patients. It's officially the 1st of October, so I'm seeing a lot of people coming in with the hangover from too much sun, no matter how good the sunscreen behaviour, and looking to make their skin more even toned. So if you have melasma, stay tuned. So melasma is one of the commonest causes of pigmentation I see in the clinic. Now, if you're not sure if your pigmentation is melasma, the commonest pattern of melasma is typically represented by splodges of brown or grey pigment here, 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 occasionally on the bridge of the nose. And that pattern is what we call centrofacial melasma. Now, it's often triggered in women by a change in hormonal state. So that might be pregnancy, that might be starting the contraceptive pill, or even HRT, and it's often precipitated by a period of strong sun exposure. In some cases, stopping the pill, not being pregnant anymore, the melasma fades away, fantastic. No treatment needed other than an awareness that that's part of your skin type and diligent use of sunscreen and practicing safe sun practices, which for melasma sufferers usually means minimal UV exposure and always whilst wearing a hat. But if yours persist, then you'll most likely want to seek out some form of treatment to get it back under control. And I think it's important to remember that melasma tends to be chronic in those where it doesn't fade after pregnancy or it doesn't disappear after stopping the combined pill. I say combined, it can sometimes be the progestin-only pill. So if that's you, then the things to think about are your sunscreen. And what we know is that it's important to wear broad spectrum sunscreen. UVA rays and UVB both drive this condition. I think that physical block works best and certainly tends to be the less likely to cause reactions in sensitive skin and less likely to trigger acne breakouts. And you may need a water resistant format, particularly if you live somewhere hot and sticky. So sunscreen, important to get that very basic but essential part of your routine right. And as an update, important to think about iron oxide as an extra ingredient in your sunscreen, because this also gives you protection against visible light, which we know plays a role in driving melasma in some people too. Really annoying, UV and visible light. So really important to have a strategy with your sunscreen. And I guide my patients to wear it every day, no matter what they're doing. Even if you're staying in the house, bear in mind UV comes through glass. If you're in the car, you're going to be exposed to UV rays as well. And visible light, we can't really avoid that. So just find a sunscreen that works for you every day so you're not tempted to skip it on days when you're maybe not out and about so much. If you live somewhere hot and sunny, you're going to need to reapply. So try working a tinted sunscreen into your everyday routine, which gives you a base that you can then top up as your day proceeds. So that's sunscreen, nothing much new to report there. On to actives then. So any good routine where we're not just trying to prevent melasma, we're trying to treat it, involves active ingredients. So if you're not pregnant, then that means a retinoid. It means probably vitamin C as an antioxidant, and it probably means some form of melanocyte suppressor, something to quell those overactive pigment cells. Gold standard is still hydroquinone. I never use more than 4% strength in my practice. Alternatives to hydroquinone include azelaic acid, arbutin, and kojic acid. I have to say that in my practice I use mainly hydroquinone and azelaic acid in rotation, with occasional use of arbutin. It really very much depends on how sensitive someone's skin is. Pregnancy, you can use azelaic acid quite safely in conjunction with vitamin C with good sunscreen, and I'll also supplement with niacinamide, something I also do in patients who are not pregnant, particularly if they are tending towards more dryness and sensitivity with retinoid use. So at this time of year, I'm typically considering a more active treatment cycle with hydroquinone, which I'll do for 3 months to get someone's post-summer melasma under control. Or if someone's had a good summer and not particularly been prone to relapse, we might think about moving them onto a gentler routine. So I tend to cycle patients through blocks of treatment with different actives, depending on when we're trying to get them to look their best, their skin it's most even. So if someone has a winter wedding, I'll be most aggressive before that for obvious reasons. Whereas for someone else, they want the clearest pigment-free skin over summer, because then there's less reliance on makeup at a time of year where perhaps heavy coverage isn't ideal because of warmer temperatures. So that's my approach to topicals at this time of year. And I suppose the main thing that in my practice that is new is my use of oral tranexamic acid. So this is the first oral treatment that really has shown promise for melasma. And it's something I've been getting great results with in the last 18 months of using it in my practice. So what is tranexamic acid? Well, it's a drug that's far more familiar to our gynecology colleagues because they use it to treat women with heavy periods, or menorrhagia is the technical term. Why is it helpful in melasma? Well, what it does, it suppresses the activation of plasmin, which is part of our inflammatory cascade. And this helps reduce the presence of something called mast cells in our skin, and it reduces angiogenesis, so its effect on a protein called VEGF. And it probably also has a direct impact on melanocytes themselves, leading to them being less activated over time. So the original studies, I think, came out of Korea, and there is growing evidence base now for this medication, although it's still currently on license for this use. But as I say, we're seeing good results at relatively low doses, much lower than is typically used by the gynecologists. And the way I'm using it in practice is to treat people over the summer and then give them a break over the winter. So if you have melasma, particularly if you have more severe melasma, it does seem to be working better in the more severe candidates. It's certainly something worth discussing with your doctor. Caveats with it, because it's a drug that's used to reduce the risk of heavy bleeding, it's not indicated in those who've had a history of clots such as deep vein thrombosis, or in someone who's got a strong family history. So again, with any drug, you need to weigh up the pros and cons of starting something and view it in context of a patient's individual presentation and history. And the final thing to say about tranexamic acid is that studies have been done to look at its effect topically or indeed when injected into the skin, and so far it appears that oral treatment with tranexamic acid trumps both of those. So there you have it. I think a significant move forward in the treatment of melasma, certainly in my practice, with a new oral option to supplement the use of topicals. We're still very reliant on managing behaviour when it comes to preventing melasma relapses. But I think there is great potential for improvement, and I know this is a condition that has a huge amount of impact on many of you in terms of your everyday life because of how much limitation it can lead to. So I would urge you to get some form of treatment plan in place. And if you've had experience of any of the treatments I've discussed today, I'd love to hear more from you and hear about your successes. If you like this content, please hit subscribe, and I look forward to seeing you again next time. Bye for now.